A 48-year-old woman comes to the physician because of an increasingly painful swelling behind her right knee. Okay. Baker's cyst, intermittent low-grade fevers, and has been more fatigue. Okay, that's interesting. She has not had any trauma today. Okay. Pain in her hands and wrists bilaterally. She has hypertension, and she drinks 1 to 2 glasses of wine daily. Okay. Osteoarthritis, history of arthritis. Okay. She's really not that heavy. 3 centimeter non-tender mass in the right popliteal fossa that becomes prominent when the knee is extended. So yeah, that's a Baker's cyst. There's mild swelling and redness of her right knee joint. Swelling and redness of her right knee joint, which is where you have the Baker's cyst. Interesting. So let's think about it. I mean, these conditions that affect the joints will increase your likelihood of getting something like a Baker's cyst. So we're thinking about OA, psoriasis. It's not an aneurysm, so let's get rid of that. It's not gout. It's not lupus. She doesn't really have any signs of psoriatic arthritis. There's really no rash here, and I don't know. It doesn't really seem like that. So we're thinking about OA versus rheumatoid arthritis. So the question is, where would we have a higher incidence of Baker's disease? I feel like OA, but this person's kind of young. Young, really no risk factors for OA. I would say this is tough, but it's mild swelling and redness. Honestly, it's probably OA. Oh, it's rheumatoid. The question is why. Let's try to dig into this. Synovial inflammation, which may result in excess production of synovial fluid, inflammatory joint diffusion, and subsequently formation of a Baker's cyst. Okay, so the constitutional symptoms. Yeah, so see, it's the constitutional symptoms here that really don't support a diagnosis of OA. So let's stick with that. But obviously, with rheumatoid arthritis, you're going to produce more synovial fluid. You're going to have a higher likelihood of essentially like creating something like a Baker's cyst. I mean, let's see if we have any hockey cards that we could use. Probably not. I mean, this is kind of just like a concept. I'm not really gonna mess around with this besides just understanding now that those constitutional things will help me differentiate. Women aged 40 to 50, morning stiffness with systemic symptoms. Okay, yeah, this is a good card. Like, I'll take it. I'll take that one. I'll take that one. I'll take that one. All right, let's keep going. Let's move on, guys. All right, so now we have a 64-year-old female. She's in the ED. She says, my chest hurts, especially when I take a deep breath. PE, pericarditis, stuff like that. 2 hours, pretty acute. So, 2 hour history. Pleuritic chest pain. She has rheumatoid arthritis, major depressive. She's on methotrexate, low folic acid, fluoxetine. Okay, does not smoke. Drinks 1 glass of bourbon every night. It's not great, but whatever. Let's see. So signs are kind of normal. You know, like appearance sitting forward at the edge of the hospital bed, uncomfortable. Yes. So this is like, yeah, okay. Scratching sound is best heard over the left sternal border pericarditis. Pain is not reproducible. Pain is worse when the patient is lying back. Okay, of course. Yeah, no tender starting. Okay, cool. And this is swelling of the wait. Tenderness, palpation, stiffness, and swelling of the metacarpal phalangeal and proximal interphalangeal of the fingers. So he has rheumatoid arthritis, what we said that we established here. Spawn neck deformities plus ulnar deviation in several fingers. Firm non-tender nodules. Okay, of course. So an ECG is most likely to show which of the following findings. So what are ECG findings of pericarditis? I mean, diffuse ST elevations, classic feature. We're going to go with that. Concave, so convex versus concave. Diffuse ST depressions, actually. So yeah, it is this one. Okay, my bad. Let's go for that. Diffuse concave ST segment elevation. Okay. Nothing in AVR, nothing in V1. ST segment depressions. PR segment depression. Viral. She has rheumatoid arthritis. She has autoimmune disease. Uh, We're gonna treat with NSAIDs or equal vitamins. Let's take a look at the EKG. So there's the ST segment. It's elevated, it's elevated, it's elevated. Cool. Nothing for this. I'm not making cards or anything. All right, let's keep going. Let's keep going. Now we have a 31-year-old man comes to the physician for a follow-up. Uh, tingling and numbness of his legs for the past 10 days. I mean, that could be so many things. Tired. So maybe he has anemia. 3 months ago, he's diagnosed with tuberculosis and started on anti-tuberculosis therapy. Well, there you go. It was probably the freaking I forgot the name of the drug, but it kills your vitamin B6. Oh, isoniazid. My bad. Pale. Scaly lips. Okay, crap. Oh, yes, chylosis. Okay, great. Okay. Membrane to go. Okay. Yes, he's anemic. It's a microcytic anemia, which is interesting. I think sideroblastic anemia, which is vitamin B6 deficiency, is usually microcytic, so that's consistent. And actually, which the volume most likely to. I mean, this is just, yeah, I mean, there it is, right there. All right. Since pyridoxine is an essential cofactor in the synthesis of neurotransmitters and heme, patients with a chronic pyridoxine deficiency develop sensory peripheral neuropathy and sideroblastic anemia. Great. While pyridoxine deficiency is rare in the general population, it is common seen in association with isoniazid acid used in the treatment of tuberculosis treatment because there's a to prevent peripheral neuropathy, supplemental pyridoxine should therefore be added as an adjuvant treatment. What's this? Against seizures, irritability, peripheral neuropathy, subderm, glossitis, chylitis, sideroblastic anemia, which is characterized by ring sideroblast in the bone marrow associated with drug use. Okay, whatever. Fantastic. Let's keep going. Let's keep going. Now we have a 59-year-old man comes to the physician because of a 3-month history of frequent urination, diabetes maybe. He also had to urinate every 1 to 2 hours in the day, wakes up at least maybe pH. The difficulty urinating, initiating maturation, the urination rate pH well. Prolonged terminal dribbling, of course. Right there, smooth, symmetrically enlarged prostate. There you go. Without any tenderness irregularities, prostatic antigen is normal. Great. Postpartum ultrasound is I don't really remember, but I don't think this is great. So there's obstruction. Which of the following is the most appropriate next step? I mean, he's just been having lower urinary tract symptoms, so I don't need to catheterize him right now. Go straight to TERP. That's a little invasive. Biopsy does not. Am I just gonna remove his prostate? It doesn't make any sense. So let's think. We're here between cystoscopy. We're between terazosin and finasteride. I mean, this guy, his blood pressure is elevated, and we might as well knock 2 birds with 1 stone. Let's go with terazosin. Okay. Alpha blockers are the first-line pharmacotherapy in most patients with symptomatic BPH and decreased quality of life. Alpha blockers smooth muscle relaxants, which you can resistance to form by causing smooth muscle relaxation of the bladder, neck, and urethra. Okay, thereby causing symptomatic improvement in patients with BPH. Alpha blockers do not reverse prostatic hyperplasia, but they can provide rapid improvement. Why not? Okay, so they didn't even mention the. PSA greater than 1.5. I think we have to keep that as like a nice factoid. So finasteride is for high PSA too. Okay, we'll keep that in mind. All right, let's keep going. Let's keep going. We have a 24-year-old woman comes to the physician because she had unprotected sexual intercourse with her boyfriend 2 days ago. She wants to avoid pregnancy in the next month because she's finishing college but would like to conceive after that. I mean, she wants emergency contraception because she's had unprotected sex 2 days ago. Her pregnancy test is negative. She does not exclude pregnancy. Um, I mean, mifepristone, crystal acetate, depot, hydroxyprogesterone. Well, this is not gonna act like like we're not just gonna go for this. Mifepristone, crystal. Yeah, I think that's one of the emergency contraception. It's very interesting. So much to learn from this one. I should really. Right. Severely anemic. Jesus. Not responding well. Mainly indirect, not direct. It's hemolyzing.